Welcome to this video entitled Inflammatory Bowel Disease. Let's now consider a definition. There are two forms of idiopathic inflammatory bowel disease, abbreviated as IBD: ulcerative colitis, a mucosal inflammatory condition confined to the rectum and colon, and Crohn's disease, a transmural inflammation of gastrointestinal mucosa that may occur in any part of the gastrointestinal tract. The etiologies of both conditions are unknown, but they may have a common pathogenetic mechanism. We will now look at the pathophysiology of inflammatory bowel disease. 1. The major theories of the cause of inflammatory bowel disease involve a combination of infectious, genetic, and immunologic causes. The inflammatory response with inflammatory bowel disease may indicate abnormal regulation of the normal immune response or an autoimmune reaction to self-antigens. Microflora of the gastrointestinal tract may provide a trigger to activate inflammation. Crohn's disease may involve a T lymphocyte disorder that arises in genetically susceptible individuals as a result of a breakdown in the regulatory constraints on mucosal immune responses to enteric bacteria. Proposed etiologies for inflammatory bowel disease are found in Table 26(1). 2. Smoking appears to be protective for ulcerative colitis, but associated with increased frequency of Crohn's disease. 3. Ulcerative colitis and Crohn's disease differ in two general respects: anatomic sites and depth of involvement within the bowel wall. There is, however, overlap between the two conditions, with a small fraction of patients showing features of both diseases. Table 26(2). Let's now focus on ulcerative colitis. 1. Ulcerative colitis is confined to the colon and rectum and affects primarily the mucosa and the submucosa. The primary lesion occurs in the crypts of the mucosa, crypts of Lieberkühn, in the form of a crypt abscess. 2. Local complications, involving the colon, occur in the majority of ulcerative colitis patients. Relatively minor complications include hemorrhoids, anal fissures, or perirectal abscesses. 3. A major complication is toxic megacolon, a severe condition that occurs in up to 7.9% of ulcerative colitis patients admitted to hospitals. The patient with toxic megacolon usually has a high fever, tachycardia, distended abdomen, elevated white blood cell count, and a dilated colon. 4. The risk of colonic carcinoma is much greater in patients with ulcerative colitis as compared with the general population. 5. Approximately 11% of patients with ulcerative colitis have hepatobiliary complications including fatty liver, pericholangitis, chronic active hepatitis, cirrhosis, sclerosing cholangitis, cholangiocarcinoma, and gallstones. 6. Arthritis commonly occurs in inflammatory bowel disease patients and is typically asymptomatic and migratory. Arthritis typically involves one or a few large joints such as the knees, hips, ankles, wrists, and elbows. 7. Ocular complications, iritis, episcleritis, and conjunctivitis, occur in up to 10% of patients. 5% to 10% of patients experience dermatologic or mucosal complications, erythema nodosum, pyoderma gangrenosum, aphthous stomatitis. Pause the video and carefully scrutinize Table 26(1) summarizing proposed etiologies for inflammatory bowel disease before advancing to the next slide. Pause the video and carefully scrutinize Table 26(2) summarizing comparison of the clinical and pathologic features of Crohn's disease and ulcerative colitis before advancing to the next slide. We will now shift gears to Crohn's disease. 1. Crohn's disease is a transmural inflammatory process. The terminal ileum is the most common site of the disorder, but it may occur in any part of the gastrointestinal tract. 2. About 2/3 of patients have some colonic involvement, and 15% to 25% of patients have only colonic disease. 3. Patients often have normal bowel separating segments of diseased bowel. That is, the disease is often discontinuous. 4. Complications of Crohn's disease may involve the intestinal tract or organs unrelated to it. Small bowel stricture and subsequent obstruction is a complication that may require surgery. Fistula formation is common and occurs much more frequently than with ulcerative colitis. 5. Systemic complications of Crohn's disease are common and similar to those found with ulcerative colitis. Arthritis, iritis, skin lesions, and liver disease often accompany Crohn's disease. 6. Nutritional deficiencies are common with Crohn's disease. We will now discuss the clinical presentation of ulcerative colitis. 1. There are a wide range of ulcerative colitis presentations. Symptoms may range from mild abdominal cramping with frequent small volume bowel movements to profuse diarrhea, as shown in Table 26.3. Many patients have disease confined to the rectum, that is proctitis. 2. Most patients with ulcerative colitis experience intermittent bouts of illness after varying intervals of no symptoms. 3. Mild disease, which afflicts 2/3 of patients, has been defined as fewer than 4 stools daily, with or without blood, with no systemic disturbance and a normal erythrocyte sedimentation rate. 4. Patients with moderate disease have more than 4 stools per day, but with minimal systemic disturbance. 5. With severe disease, the patient has more than 6 stools per day with blood, with evidence of systemic disturbance as shown by fever, tachycardia, anemia, or erythrocyte sedimentation rate greater than 30. Pause the video and carefully scrutinize Table 26.3 summarizing the clinical presentation of ulcerative colitis before advancing to the next slide. Pause the video and carefully scrutinize Table 26.4 summarizing the clinical presentation of Crohn's disease before advancing to the next slide. We will now pay close attention to Crohn's disease. 1. As with ulcerative colitis, the presentation of Crohn's disease is highly variable, as shown in Table 26.4. A single episode may not be followed by further episodes, or the patient may experience continuous, unremitting disease. A patient may present with diarrhea and abdominal pain or a perirectal or perianal lesion. 2. The course of Crohn's disease is characterized by periods of remission and exacerbation. Some patients may be free of symptoms for years, while others experience chronic problems in spite of medical therapy. And now let's consider the desired outcome. Goals of treatment include resolution of acute inflammatory processes, resolution of attendant complications, e.g., fistulas, or abscesses, alleviation of systemic manifestations, e.g., arthritis, maintenance of remission from acute inflammation, or surgical palliation or cure. Next we will discuss the treatment of inflammatory bowel disease. We will begin with a general approach. 1. Treatment of inflammatory bowel disease centers on agents used to relieve the inflammatory process. Salicylates, glucocorticoids, antimicrobials, and immunosuppressive agents are commonly used to treat active disease and, for some agents, to lengthen the time of disease remission. 2. In addition to the use of drugs, Surgical procedures are sometimes performed when active disease is not adequately controlled or when the required drug dosages pose an unacceptable risk of adverse effects. And now let's look at the non-pharmacologic treatment of inflammatory bowel disease. Let's begin with nutritional support. 1. Patients with moderate to severe inflammatory bowel disease are often malnourished. 2. The nutritional needs of the majority of patients can be adequately addressed with enteral supplementation. Patients who have severe disease may require a course of parenteral nutrition. 3. Probiotic formulas have been effective in maintaining remission in ulcerative colitis. Next we will focus on surgery. 1. For ulcerative colitis, colectomy may be performed when the patient has disease uncontrolled by maximum medical therapy or when there are complications of the disease such as colonic perforation, toxic dilatation, that is megacolon, uncontrolled colonic hemorrhage, or colonic strictures. 2. The indications for surgery with Crohn's disease are not as well established as they are for ulcerative colitis, and surgery is usually reserved for the complications of the disease. There is a high recurrence rate of Crohn's disease after surgery. Next we will discuss the pharmacologic therapy of inflammatory bowel disease. 1. The major types of drug therapy used in inflammatory bowel disease include aminosalicylates, glucocorticoids, immunosuppressive agents, such as azathioprine, mercaptopurine, cyclosporine, and methotrexate, antimicrobials, such as metronidazole and ciprofloxacin, and agents to inhibit tumor necrosis factor alpha, TNF-alpha, anti-TNF-alpha antibodies. 2. Sulfasalazine, an agent that combines a sulfonamide, sulfapyridine, antibiotic and mesalamine, that is 5-aminosalicylic acid, in the same molecule, has been used for many years to treat inflammatory bowel disease. Mesalamine-based products are listed in Table 26.5. 3. Corticosteroids and adrenocorticotropic hormone have been widely used for the treatment of ulcerative colitis and Crohn's disease and are used in moderate to severe disease. Prednisone is most commonly used. Budesonide is an oral controlled release formulation that minimizes systemic effects. 4. Immunosuppressive agents such as azathioprine and mercaptopurine, a metabolite of azathioprine, are sometimes used for the treatment of inflammatory bowel disease. These agents are generally reserved for cases that are refractory to steroids and may be associated with serious adverse effects such as lymphomas, pancreatitis, or nephrotoxicity. Cyclosporine has been of short-term benefit in acute, severe ulcerative colitis when used in a continuous infusion. 5. Methotrexate given 15 to 25 mg intramuscularly once weekly is useful for treatment and maintenance of Crohn's disease. 6. Antimicrobial agents, particularly metronidazole, are frequently used in attempts to control Crohn's disease, particularly when it involves the perineal area or fistulas. 7. Infliximab is an anti-TNF antibody that is useful in moderate to severe active disease and steroid-dependent or fistulizing disease, but the cost far exceeds that of other regimens. Adalimumab is another anti-TNF antibody that is an option for patients with moderate to severe active Crohn's disease previously treated with infliximab who have lost response. Pause the video and carefully scrutinize Table 26.5 summarizing mesalamine derivatives for treatment of inflammatory bowel disease before advancing to the next slide. Let's now focus on ulcerative colitis. We will begin with mild to moderate disease. 1. The first line of drug therapy for the patient with mild to moderate colitis is oral sulfasalazine or an oral mesalamine derivative, or topical mesalamine or steroids for distal disease, shown in Figure 26.1. 2. When given orally, usually 4 grams per day, up to 8 grams per day of sulfasalazine is required to attain control of active inflammation. Sulfasalazine therapy should be instituted at 500 mg per day and increased every few days up to 4 grams per day, or the maximum tolerated. 3. Oral mesalamine derivatives, such as those listed in Table 26.5, are reasonable alternatives to sulfasalazine for treatment of ulcerative colitis, but they are not more effective than sulfasalazine. 4. Steroids have a place in the treatment of moderate to severe ulcerative colitis that is unresponsive to maximal doses of oral and topical mesalamine. Prednisone up to 1 mg per kilogram per day or 40 to 60 mg daily may be used for patients who do not have an adequate response to sulfasalazine or mesalamine. 5. Steroids and sulfasalazine appear to be equally efficacious. However, the response to steroids may be evident sooner. 6. Rectally administered steroids or mesalamine can be used as initial therapy for patients with ulcerative proctitis or distal colitis. 7. Transdermal nicotine improved symptoms of patients with mild to moderate active ulcerative colitis in daily doses of 15 to 25 mg. Pause the video and carefully scrutinize Figure 26.1 summarizing treatment approaches for ulcerative colitis before advancing to the next slide. Let's now consider severe or intractable disease. 1. Patients with uncontrolled severe colitis or incapacitating symptoms require hospitalization for effective management. Most medication is given by the parenteral route. 2. With severe colitis, there is a much greater reliance on parenteral steroids and surgical procedures. Sulfasalazine or mesalamine derivatives have not been proven beneficial for treatment of severe colitis. 3. Steroids have been valuable in the treatment of severe disease because the use of these agents may allow some patients to avoid colectomy. A trial of steroids is warranted in most patients before proceeding to colectomy, unless the condition is grave or rapidly deteriorating. 4. Continuous IV infusion of cyclosporine, dosed at 4 mg per kilogram per day, is recommended for patients with acute severe ulcerative colitis refractory to steroids. Next we will discuss maintenance of remission. 1. Once remission from active disease has been achieved, the goal of therapy is to maintain the remission. 2. The major agents used for maintenance of remission are sulfasalazine, dosed at 2 grams per day, and the mesalamine derivatives, although mesalamine is not as effective as sulfasalazine. 3. Steroids do not have a role in the maintenance of remission with ulcerative colitis, because they are ineffective. Steroids should be gradually withdrawn after remission is induced, over 3 to 4 weeks. If they are continued, the patient will be exposed to steroid side effects without likelihood of benefits. 4. Azathioprine is effective in preventing relapse of ulcerative colitis for periods exceeding 4 years. However, 3 to 6 months may be required for beneficial effect. For patients who initially respond to infliximab, continued administration of 5 mg per kilogram every 8 weeks as maintenance therapy is an alternative for steroid-dependent patients. We will now focus on Crohn's disease as shown in Figure 26.2. Let's begin with active Crohn's disease. 1. The goal of treatment for active Crohn's disease is to achieve remission. However, in many patients, reduction of symptoms so that the patient may carry out normal activities, or reduction of the steroid dose required for control is a significant accomplishment. 2. In the majority of patients, active Crohn's disease is treated with sulfasalazine, mesalamine derivatives, or steroids, although azathioprine, mercaptopurine, methotrexate, infliximab, and metronidazole are frequently used. 3. Sulfasalazine is more effective when Crohn's disease involves the colon. 4. Mesalamine derivatives, such as pentasa or asacol, that release mesalamine in the small bowel may be more effective than sulfasalazine for ileal involvement. 5. Steroids are frequently used for the treatment of active Crohn's disease, particularly with more severe presentations, or in those patients unresponsive to aminosalicylates. Budesonide is a viable first-line option for patients with mild to moderate ileal or right-sided disease. Systemic steroids induce remission in up to 70% of patients and should be reserved for patients with moderate to severe disease who have failed aminosalicylates or budesonide. 6. Metronidazole, given orally up to 20 mg per kilogram per day, may be useful in some patients with Crohn's disease, particularly in patients with colonic or ileocolonic involvement or those with perineal disease. The combination of metronidazole with ciprofloxacin is efficacious in some patients. 7. The immunosuppressive agents, azathioprine and mercaptopurine, are generally limited to use in patients not achieving adequate response to standard medical therapy, or to reduce steroid doses when toxic doses are required. The usual dose of azathioprine is 2 to 3 mg per kilogram per day and 1 to 1.5 mg per kilogram per day for mercaptopurine. Up to 3 to 4 months may be required to observe a response. Starting doses are typically 50 mg per day and increased at 2-week intervals while monitoring complete blood count with differential. 8. Patients deficient in thiopurine S-methyltransferase, abbreviated as TPMT, are at greater risk of bone marrow suppression from azathioprine and mercaptopurine. Determination of thiopurine S-methyltransferase or thiopurine S-methyltransferase genotype is recommended to guide dosage. 9. Cyclosporine is not recommended for Crohn's disease except for patients with symptomatic and severe perianal or cutaneous fistulas. The dose of cyclosporine is important in determining efficacy. An oral dose of 5 mg per kilogram per day was not effective, whereas 7.9 mg per kilogram per day was effective. However, toxic effects limit application of the higher dosage. Dosage should be guided by cyclosporine whole blood concentrations. 10. Methotrexate, given as a weekly injection of 5 to 25 mg, has demonstrated efficacy for induction of remission in Crohn's disease as well as for maintenance therapy. The risks are bone marrow suppression, hepatotoxicity, and pulmonary toxicity. 11. Infliximab is used for moderate to severe active Crohn's disease in patients failing immunosuppressive therapy, in those who are corticosteroid dependent, and for treatment of fistulizing disease. A single, 5 mg per kilogram infusion is effective when given every day for 8 weeks. Additional doses at 2 and 6 weeks following the initial dose results in higher response rates. 12. Adalimumab is effective in 54% of patients with moderate to severe Crohn's disease who have lost response to infliximab. The typical dosage is 160 mg subcutaneously initially, followed by 80 mg subcutaneously at week 2, with subsequent doses of 40 mg subcutaneously every other week thereafter. We will now consider maintenance of remission. 1. Prevention of recurrence of disease is clearly more difficult with Crohn's disease than with ulcerative colitis. Sulfasalazine and oral mesalamine derivatives are effective in preventing acute recurrences in quiescent Crohn's disease. 2. Steroids also have no place in the prevention of recurrence of Crohn's disease. These agents do not appear to alter the long-term course of the disease. 3. Although the published data are not consistent, there is evidence to suggest that azathioprine, mercaptopurine, methotrexate, infliximab, and adalimumab are effective in maintaining remission in Crohn's disease. Pause the video and carefully scrutinize Figure 26.2 illustrating the treatment approaches for Crohn's disease before advancing to the next slide. Let's now focus on selected complications. We will begin with toxic megacolon. 1. The treatment required for toxic megacolon includes general supportive measures to maintain vital functions, consideration for early surgical intervention, and antimicrobials. 2. Aggressive fluid and electrolyte management are required for dehydration. 3. When the patient has lost significant amounts of blood through the rectum, blood replacement is also necessary. 4. Steroids in high dosages, i.e. hydrocortisone 100 mg every 8 hours, should be administered intravenously to reduce acute inflammation. 5. Antimicrobial regimens that are effective against enteric aerobes and anaerobes should be administered as preemptive therapy in the event that perforation occurs. We will now shift gears to systemic manifestations of inflammatory bowel disease. 1. The common systemic manifestations of inflammatory bowel disease include arthritis, anemia, skin manifestations such as erythema nodosum and pyoderma gangrenosum, uveitis, and liver disease. 2. Anemia may be a common problem where there is significant blood loss from the gastrointestinal tract. When the patient can consume oral medication, ferrous sulfate should be administered. Vitamin B12 or folic acid may also be required. Let's now progress to special considerations. We will begin with pregnancy. 1. Drug therapy for inflammatory bowel disease is not a contraindication for pregnancy, and most pregnancies are well managed in patients with these diseases. The indications for medical and surgical treatment are similar to those in the non-pregnant patient. If a patient has an initial bout of inflammatory bowel disease during pregnancy, a standard approach to treatment with sulfasalazine or steroids should be initiated. 2. Folic acid supplementation, 1 mg twice daily, should be given. 3. Metronidazole or methotrexate should not be used during pregnancy. Azathioprine and mercaptopurine may be associated with fetal deformities. We will now look at adverse drug reactions to agents used for treatment of inflammatory bowel disease. 1. Sulfasalazine is often associated with either dose-related or idiosyncratic adverse drug effects. Dose-related side effects usually include gastrointestinal disturbances such as nausea, vomiting, diarrhea, or anorexia, but may also include headache and arthralgia. 2. Patients receiving sulfasalazine should receive oral folic acid supplementation since sulfasalazine inhibits folic acid absorption. 3. Non-dose-related adverse effects of sulfasalazine include rash, fever, or hepatotoxicity most commonly, as well as relatively uncommon but serious reactions such as bone marrow suppression, thrombocytopenia, pancreatitis, pneumonitis, interstitial nephritis, and hepatitis. 4. Oral mesalamine derivatives may impose a lower frequency of adverse effects compared with sulfasalazine. Up to 90% of patients who are intolerant to sulfasalazine will tolerate oral mesalamine derivatives. Alsalazine may cause watery diarrhea in up to 25% of patients. 5. The well-appreciated adverse effects of glucocorticoids include hyperglycemia, hypertension, osteoporosis, fluid retention and electrolyte disturbances, myopathies, psychosis, and reduced resistance to infection. In addition, glucocorticoid use may cause adrenocortical suppression. Specific regimens for withdrawal of glucocorticoid therapy have been suggested. 6. Immunosuppressants such as azathioprine and mercaptopurine have a significant potential for adverse reactions, including bone marrow suppression, and have been associated with lymphomas in renal transplant patients, and pancreatitis. Myelosuppression resulting in leukopenia is related to a deficiency in thiopurine S-methyltransferase in some patients. 7. Infliximab has been associated with infusion reactions, serum sickness, sepsis, and reactivation of latent tuberculosis. Adalimumab carries risks similar to infliximab. Finally, we will discuss evaluation of therapeutic outcomes. 1. The success of therapeutic regimens to treat inflammatory bowel diseases can be measured by patient-reported complaints, signs and symptoms, direct physician examination, including endoscopy, history and physical examination, selected laboratory tests, and quality of life measures. 2. To create more objective measures, disease rating scales or indices have been created. The Crohn's Disease Activity Index is a commonly used scale, particularly for evaluation of patients during clinical trials. The scale incorporates 8 elements, namely: 1. Number of stools in the past 7 days. 2. Sum of abdominal pain ratings from the past 7 days. 3. Rating of general well-being in the past 7 days. 4. Use of antidiarrheals. 5. Body weight. 6. Hematocrit. 7. Finding of abdominal mass. And 8. A sum of symptoms present in the past week. Elements of this index provide a guide for those measures that may be useful in assessing the effectiveness of treatment regimens. 3. Standardized assessment tools have also been constructed for ulcerative colitis. Elements in these scales include the following: 1. Stool frequency. 2. Presence of blood in the stool. 3. Mucosal appearance, from endoscopy. And 4. Physician's global assessment based on physical examination, endoscopy, and laboratory data. Thank you.